Afternoon, Dr. Doseko.
Hello. Whose voice is that? Angelic voice is that?
Angelic voice. So,
Yeah.
Chinyere, Ezeaka.
How are you, Ezeaka?
Fine, thank you, ma'am. Thank you so much.
Okay. All right, it's 3 o'clock. I want to keep to our tradition of beginning on time. So with due permission, I want to get the meeting rolling. So I want to welcome you all again. My name is Dr. Leo Dudu. I'm the Clinical Director of ML Hospital and a consultant pediatrician. I welcome you again to another session of the Guild of Pediatricians in Private Practice. Today offers us another opportunity to gain knowledge and as well as strengthen our collaboration with our colleagues, pediatricians in the academia. Today we have an interesting topic, neonatal hyperbilirubinemia/acute bilirubin encephalopathy, updates and recent advances in management. And we are privileged today to have the opportunity of listening to no less a person than Professor Chinyere Ezeaka, a professor of neonatology and perinatology at the College of Medicine, University of Lagos. She is also a former president of NISOM, that's the Neonatal Society of Nigeria. Well, I think I don't have to say more because we all know Professor Ezeaka's passion for the newborn. And you have to see her really display this in the NISOM meeting, and then that when newborns at with Professor Ezeaka. Well, she's an excellent teacher, a researcher. For me, most of all, an amiable and a very good person. That says much for every other thing. And before I go on, lay too much accolade on her, maybe I should also make a full disclosure. She is my teacher. He was and is my teacher. So, and also the supervisor of my dissertation. So you can see where my soft spot is here. So I can go on talking about her forever. So then I'm really very honored to be introducing you in a forum like this. Welcome, ma'am.
Thank you so much.
Thank you. This session will be moderated by another giant in neonatology. I describe her as indefatigable Dr. Fumbo Doseko, who is one of the forerunners in private practice when we talk about neonatal medicine. She's a trailblazer, a teacher, an excellent clinician, and we were really honored that she could find time to do this session today. Good afternoon, ma'am. Welcome.
Good afternoon. I hope you can all hear me.
Yeah, we can, ma'am. So, as customary, I would hand over to the chairman and the initiator of this forum, Dr. Mobolaji Lawal, for his opening remarks. Sir.
Yeah, thank you very much, Leo. Once again, I have great pleasure in welcoming everyone to this meeting. I hope I'm audible.
Yes, sir.
Okay. There is no better person to address the topic of today than the presenter, Professor Ezeaka, who has been so ably described by one of her mentees. It's a pleasure to welcome you again, Prof.
Thank you, sir.
Yes, we also have the privilege of having a senior pediatrician, Dr. Doseko, who has also been very well described by by Dr. Dudu. By the way, Dr. Dudu is standing in for Dr. Eletu, who is unavoidably absent. He's traveling at the moment. And he is a member of the committee for this group. Dr. Dosekun, as we all know, he has demonstrated tremendous passion for treating premature babies in the community. And he has gathered a lot of experience in managing these small babies in the private sector. So we have a rich mix of resource people today. And I look forward to a very educative and interesting session. And if there's any pediatrician who is wondering, what he has to learn from, updates and recent advances in management of neonatal hyperbilirubinemia and acute bilirubin encephalopathy, you just need to hold your breath a little while, and you will see what you have to learn shortly. So I welcome you once again. I'm very pleased that many people already logged in. So on that note, I would like to hand over to Dr. Odudu to continue with the program. Thank you.
Thank you very much, sir. I think at this time I'll hand over to Dr. Dosekun to take on from here. Dr. Dosekun, please.
So good afternoon, colleagues. It gives me great joy to be the moderator of this very important topic that affects our neonates. Can you hear me?
Yeah, okay.
Yes.
Now we can now, yes. Hello, ma'am. Hello. We've lost your voice a bit.
Okay, sorry, yes. I said there's no reason why jaundice should still be a problem amongst our children. So the more we learn about new advances, new policies, new service delivery, new research, better for us. We are so fortunate to have with us a brilliant and hardworking doctor in the name of Professor Veronica Chinyere Ezeaka. She works in LUF, but is not a local player alone. She's an international player working as a visiting professor.
Again.
She works also in hospitals in America, in New York. There's Cohen Children's Hospital, and there's County Hospital in Minnesota. I think there are very few academics that have that opportunity. She's a very special lady that understood the importance of strategic alliances and networking. And she has used it to her fullest advantage and to the advantage of her community. Her leadership role in pediatrics and neonatology is famed. She has done very well for herself and for patients to her name. I think this is an incredible achievement. Dr. Ezeaka is very appreciated by the Federal Ministry of Health. She has done a lot of consultancy, advisory work for them. Also Save the Children, USAID, etc., etc. It is with great admiration, that's a word I can use, I present this wonderful, hardworking doctor, Professor Ezeaka, to deal with this very important topic of neonatal jaundice amongst our children. Let's learn what is new, and let's mobilize ourselves to become forces to create change in the policy, in the way we do surveillance for children with jaundice. Thank you. Dr. Ezeaka, over to you.
Wow, thank you so much, and very warm greetings to everyone and to the entire alumni for this opportunity for me to be here for us to share knowledge and have a deeper dive at understanding what can we do about this major preventable cause of death in our newborn. I must greet and revere our esteemed elder sir here, Dr. Adeni Fuja. Thank you so much, sir, for being here. The chairman, Dr. Mubala Dilawa, thanks so much. Dr. Deseku, Dr. Leo, Dr. Eletu, for the entire committee, for this extreme laudable initiative for us to all share information periodically amongst ourselves. Thank you. And again, I'm greatly appreciative of everyone who is here. What can we do about jaundice in Nigeria? So I want to start with a clinical scenario that will take a few minutes to say clinical scenario, then we go into pathophysiology, and then what is the managerial strides, and then we'll mention a few things that are new. But at the end of the day, how can we improve the care of these babies? We had morbidity mortality in the department barely last week, and we're still seeing babies that are coming in with acute bilirubin encephalopathy and kernicterus, along the line, following, and death from severe jaundice. What are we going to do about these babies? So I have this scenario of unconjugated hyperbilirubinemia of a baby AO. These are the usual scenario: 5-day-old term baby referred to our emergency room, 3-day history of jaundice, and then 6 hours history of post-suck before presentation. Normal pregnancy, uncomplicated, good ABGA scores, good birth weight, 3,400 grams. But mother was discharged home within 24 hours of birth, and she tried to establish breastfeeding. Okay, this yellowness of the eyes progressed. This baby had no fever. At presentation, this baby was deeply ictenic to the sole of the foot using the Kramer chart assessment that we're going to mention during the course of the presentation. No history of seizures at this point. The stool color is yellow because these are all the details we need to get. On central nervous system examination, baby was lethargic in retrocollis position. Retrocollis is when there is arching of the neck, only the neck. Opistotonus is arching of the entire spine. All right, having occasional windmilling movement, suck and grasp reflexes were absent. Further history showed that this baby had been exposed to heterogenic agents, naphthalene balls, camphor that these mothers use for their clothes. And then they're also using mentholated balm for cut care. This will emphasize what Dr. Deseku has started. How do we get into, prevention before even then? The bind score, which is still part of this presentation, was 8. Bilirubin-induced neurological dysfunction. These are assessments for the central nervous system of this baby. And then an assessment of neonatal jaundice query G6PD deficiency with acute bilirubin encephalopathy was made. All the sample showed 37.3 milligram per deciliter of bilirubin, total bilirubin. So the mother's blood group was O positive, direct home test was negative, baby positive, B positive. G6PD showed that baby was deficient. This case was also brought out because the G6PD testing is a test we still don't routinely do, but it's still a major cause of brain damage in our babies. There was no sepsis, or the full blood count was negative for sepsis. Baby was commenced on intensive phototherapy with an irradiance of 30 microwatts. That's still, again, part of the teachings within the course of the lecture. We have to prescribe phototherapy. It's not just go under the light. So the parents were duly counseled. HA blood transfusion was done for this child, had EBT, and intensive phototherapy, because there are grading and criteria of phototherapy, whether you're doing conventional or whether you're doing intensive. Baby's clinical condition improved, and parents were educated on G6PD deficiency, and the list of drugs that trigger hemolysis was given out to them. So baby was discharged and scheduled for close neurodevelopmental monitoring and assessment. So this has really set the stage for the learnings. What are the learning objectives? What could we have done to prevent that baby getting acute bilirubin encephalopathy? So we will now go deeper into some metabolism of bilirubin, just to remind ourselves. Metabolism of bilirubin, clinical causes, complications. It's an avoidable tragedy, this acute bilirubin encephalopathy kernicterus. We go to the neurology clinics and we still see these babies with brain damage who cannot live their life potentials due to jaundice. Then what are the principles of management? And then what are some recent advances, both of them being in the experimental stage and also occasionally being utilized in some centers? And then key messages. Now to give the background about severe neonatal jaundice being a preventable cause of morbidity, mortality, and post-neonatal developmental sequelae. It is actually the commonest neonatal emergency in the first week of life. It's very prevalent, 60% of 10 neonates, and then 80 to 90, 100% of preterms will all have jaundice. We all say, oh, it's a benign condition, but the key thing about jaundice is the rapid progression. The rapid progression to acute bilirubin encephalopathy, and then the long-term impairment. The babies are well when the mothers are discharged, so everybody goes home with this euphoria, forgetting that the mother needs to know about the potentials of jaundice still damaging this baby's brain despite discharge. We remind ourselves about basics, hyperbilirubinemia, referring to accumulation of bilirubin. You know, when this bilirubin accumulates in the blood. Jaundice, yellowish discoloration of the skin, mucous membrane, and nails. And then in between all these presentations, we're saying unconjugated, indirect, because these terms are synonymous, unconjugated and indirect bilirubin. Actually, some laboratories, they just give you indirect bilirubin. That's the unconjugated fraction. And then the conjugated bilirubin is the direct bilirubin. And hyperbilirubinemia becomes evident in the skin when the level gets to about 5 to 7. But you know, many people rely on the skin, but it depends. In dark babies, it's still a bit difficult, especially when one is not too trained to blanch the baby. So it's still posing a lot of diagnostic challenges. So quick physiology around the bilirubin, just to point where the dangers are. That's in utero, because of the relative hypoxia, these babies' bone marrows are prone to produce a lot of erythrocytes, you know. But when the baby is delivered with the normal atmospheric pressure, there is physiologic breakdown of these red blood cells. And it breaks down to heme with this rate limiting step, heme oxygenate to biliverdin, and then we'll have bilirubin. It's critically important here that this bilirubin, there's some background noise, sorry. Is it just from my end? Thank you. It's critically important that this bilirubin is bound to albumin because it is the free, unbound, unconjugated bilirubin that crosses the blood-brain barrier. So we'll still look at factors whereby you may not have this binding, potentiating more bilirubin encephalopathy in these babies. So if it is that a lot of the bilirubin is bound to albumin, and then it gets into the liver for conjugation. So this conjugation makes the bilirubin to be water soluble. Unconjugated bilirubin is not water soluble, but when it's conjugated by the UDP glucuronide transferase, it becomes water soluble and now gets transported through the bile system to the intestines. Key things happen in the intestines too, which is very important, that this conjugated bilirubin needs to be decomposed by intestinal bacteria to urobilinogen and steatobilirubin. However, if this conjugation does not take place, because there are few bacteria to decompose to urobilinogen and steatobilirubin, there are some beta-glucuronidases again in the GIT that will unconjugate this bilirubin that has been conjugated. And now you're having enterohepatic circulation back into the blood. So this baby has issues with trying to wash out, because the key is to remove a lot of this bilirubin through the GIT through the stool and the urine as bilirubin and urobiology. So having said that, we need to be aware that actually there are some factors that displace bilirubin from albumin. And when it displaces bilirubin from albumin, a lot of unconjugated free bilirubin now gets into the brain of the child. So factors that decrease albumin binding include low serum albumin, asphyxia. So when babies are asphyxiated, when there are risk factors, acidosis. So we shouldn't allow asphyxiated infection, prematurity, hypoglycemia. When there are a lot of free fatty acids produced by starvation, when this baby is cold. So cold stress also makes the bilirubin not to bind to albumin. So a cold baby has more effect, has more potentials to have acute bilirubin encephalopathy compared to a baby who is more warm. Then we talk about drugs. Strong displacers, sulfonamides, cephalosporins. So that's why ceftriaxone is not a first-line drug in newborn, because it displaces the bilirubin that is bound to albumin, meaning that you now have a lot of free bilirubin getting to the brain to damage the baby's brain. Ibuprofen, sodium benzoate, these are diazepam, methicillin, carbenicillin. These are drugs that are strong displacers. Some weak displacers, which you now have to weigh the effects over which one is more critically important. Aminophylline, furosemide, thiazide, diuretics. Then it is important to know that when albumin is bound to bilirubin, it is non-toxic. But free, unbound, unconjugated bilirubin is fat soluble and can be transported across the blood-brain barrier and be deposited in certain neurons, causing damage. This is the key problem with bilirubin encephalopathy, where this free, unbound, unconjugated bilirubin, which is fat soluble, gets into the blood-brain barrier. It damages neurons, not just at the basal ganglia, but onto the anterior horn cells, cerebellum, etc. We all know about physiologic, pathologic, two major broad categories of jaundice. Because speaking to health workers one time, medical officers in Lagos State, and you talk about jaundice. Oh, they said, is it not physiologic? Most jaundice are physiologic. And this physiologic, placed at the back of our mind, is causing a lot of issues. Physiologic, baby goes home, the mother is giving ampiclox syrup, a goat, which was prescribed by a health worker or she buys by herself. And these babies, by the time they're coming to be referred in the hospital, they're already having features of acute bilirubin encephalopathy. So acute bilirubin encephalopathy is deeply preventable if both health workers, mothers, communities understand the dangers around jaundice. So that's why awareness creation is very, very key. So physiologic jaundice, we all know, appears after 24 hours. But any jaundice coming within 24 hours is pathologic. The rate of rise as stated, be it with less than 5 milligram, maximum intensity. But the key around physiologic jaundice is baby is apparently healthy. This is a well baby. You're not seeing a child who has fever or a preterm baby or a baby who is ill and you're talking about physiologic jaundice. No, it's an apparently healthy, well, active, feeding baby. And it usually results without treatment. So that's why we say that physiologic jaundice is a diagnosis of exclusion. You can't see a mother coming with a child and then you're looking at the face and say, oh, this is probably physiologic. And that is the mistake we will make. We have to monitor this baby, take the result, monitor this child over time. When it has resolved, based on the peculiarities and based on the criteria, you will now say, oh, this was physiologic jaundice. It's done at the end, not a diagnosis at the beginning. So the pathologic has its own arrays, unconjugated, conjugated, because with cholestasis, we're now seeing clays 2, white colors 2, yellow urine, but the baby is ill and it appears within 24 hours. And babies and mothers' blood group, maybe mother is blood group O and rhesus negative mother, these are all within the hemolytic range. So this graph is trying to show, in terms of the figures that we gave in the previous slide, that for the physiologic jaundice, it doesn't start within 24 hours. It starts from day 2, and then it tends to rise, peak about 6 to 8 in 10 babies, and starts to come down. You don't see physiologic jaundice getting to 14th day in 10 babies. Usually by the 10th day, it is already reducing in 10 babies. Whereas in the preterm babies, it can actually extend because of immaturity of the liver, the conjugation, excretion, up to the 14th day. So this is all physiologic. Though for preterms, it's in quotes, guarded. It's a guarded description. Like we say again, you have to monitor this baby. It has to be apparently healthy. Whereas pathologic starts from day 1 and it gets up to level of 15, etc. So a lot of physiology, most of which we know, we're just reminding ourselves. And then mechanism of physiologic jaundice, all the increased red blood cell production like we talked about earlier, due to the relative hypoxia in utero, increased production, increased rate of red blood cell degradation, defect in transport, decreased albumin. Some babies will have reduced albumin, because this is actually maybe test, like if a baby has jaundice, we may have to check, severe jaundice, what was the albumin level? Because we've just seen that if the bilirubin is not bound to albumin, it causes more free bilirubin that gets into the brain of the baby. Then we have defective uptake, defective conjugation due to the decreased uridyl glucuronide transferase activity. Decreased hepatic excretion. It's like everything is all around this baby having more jaundice physiologically. Decreased intestinal flora. It is the intestinal flora that converts the conjugated bilirubin to steatobilinogen and urobilinogen to be excreted in the stool and the urine. We see that these babies even have this decreased intestinal flora. That is why it's important to initiate breastfeeding, to have that microbiome, to have, to establish that microbiome to reduce jaundice in enterohepatic circulation. Then we still have increased enterohepatic circulation due to increased level of intestinal glucuronidases that tend to deconjugate. If it is that this baby is not having regular feeding is key, and then delayed passage of meconium. So then we look at the causes of indirect hyperbilirubinemia. Physiologically, in terms of what are the pathology, we talk about physiologic jaundice, and then disorders of production. So all these initial ones are factors that will give hemolysis. Rhesus, ABO, typically 1 gram of hemoglobin will produce 35 milligrams of unconjugated bilirubin, and this is very important. So red blood cell enzyme defects, like we have in G6PD, red blood cell structural anomalies, so all that will give hemolysis, infection, sequestration, when these babies have cephalhematomas, hemangiomas, polycythemias, infarct of diabetic mothers, hemoglobinopathy. We mentioned delayed cord clamping because it's been mentioned in the literature, but it's not been so proven, because the key thing is that it's not across all board. It's when it's now delayed more than 3 minutes, you're now having issues. Disorders of hepatic uptake. We talk about this Gilbert syndrome, where there is mutation causing decreased production of glucuronide transferase enzyme. If we remember that the glucuronide transferase enzyme conjugates bilirubin. It is mild in neonates. We talk about this Gilbert syndrome. It is mild. Then disorders of conjugation, disorders of hepatic uptake by ligandin. This is Gilbert syndrome. But the disorders of conjugation, it actually occurs, but it is rare. Type 1 is that there is complete absence of the conjugating enzyme. These babies die early because you cannot conjugate bilirubin at all. The Crigler-Najjar syndrome type 2, which is the ARIA syndrome, is reduced. The UDP glucuronide transferase enzyme is there, but it's reduced. And it actually had not been found to give kernicterus. It's actually in these babies that we talk about, phenobarbital could help to improve the activity of the minimal amount of glucuronide transferase enzyme left. Lucey-Driscoll syndrome, these are familial hyperbilirubinemia. Hypothyroidism, again, reduces conjugation. When a baby is hypothyroid, it reduces the activity of conjugating enzymes. So it gives you more unconjugated hyperbilirubinemia. And with hypothyroidism, you know, because of this reduced peristalsis, there's also increased enterohepatic circulation. So increased enterohepatic circulation, breastfeeding is very, very important, because if we delay initiation of breast milk, more of these babies will have jaundice. So breastfeeding from the teaching, essential newborn care teaching, put mother and baby to breast within 1 hour of delivery, and then baby to be fed every 2 to 3 hours. And you see that within 24, 48 hours, mother and baby have established regular flow. And this also affects the flow of the mother's breast milk if you start early. So we shouldn't just be talking about exclusive breastfeeding. It's early. That key is early, exclusive initiation. Well, you know, early initiation, exclusive breastfeeding, and then feeding the baby regularly. So delayed breastfeeding, then breast milk jaundice, this is not too common. Breast milk jaundice, where you're looking at some unidentified components in breast milk that causes increased enterohepatic recirculation. These are like the beta-glucuroninases, breaking down the conjugation that has already occurred in the GIT. So having said that, just to mention a bit about GCSPD deficiency, there's actually a cause of kernicterus in up to 35% of cases. So we should look at it and remember, especially when we have male babies, that GCSPD is still a problem with us in sub-Saharan Africa. It is sex-linked, and currently there's some studies where you can use blood cards to do screening in the hospitals, neonatal screening. So these are areas where, there's been discussed, how can it be obtained at far? But to actually think that every male neonate who is jaundice should have GCSPD screening. And looking at the clinical scenario that we presented early, before the main theme of the presentation, that baby had GCSPD. So what is the issue with GCSPD? The GCSPD enzyme, glucose phosphate dehydrogenase. So it's actually GCSPDD, So it is needed to maintain the integrity of the red blood cells. So when it is deficient, you see the hemolysis occurring, and this leads to hemolysis. There's cellular damage to the membranes, and you see hemolysis occurring. And especially in our environment where you have mothers using camphor at random, icterogenic agent, balm, rod, all mentholated eucalyptic oil. So these are all key things they need to understand during antenatal, that you don't use this for babies routinely. So this screening has to be a part of management routinely. So we have to avoid the offending trigger, treat underlying infections, and with GCSPD, phototherapy and state blood transfusion may be needed. This is just a graph to show how Nigeria is actually one of the high countries in globally where you have high rates of GCSPD deficiency from the map. These are the legends. So now GCSPD hemolysis, what normally happens is that you need the GCSPD enzyme to break down glucose phosphate to phosphogluconates. But what's needed is this NADPH is needed to maintain, the glutathione. So in the absence of the GCSPD enzyme, what happens is you have inadequate supply of this, leading to reduced level of glutathione, and then you have a lot of damage to the red blood cells. So this is a normal red blood cell, but this is the GCSPD deficient red blood cell to our right. And with this, you have membrane damaged red blood cells. You can maintain membrane stability, and then you have massive hemolysis. Now, clinically, how does this all tie? That risk factors for severe neonatal jaundice are prematurity, low birth weight, jaundice within the first 24 hours, when we have a mother who is blood group O. Anytime we have a mother who's blood group O, she has to be closely followed, because if her baby is A or B, you may have ABO incompatibility. Then rhesus negative mothers have to be closely followed. GCSPD deficiency, when there's rapid rise, when there's sepsis. Then this lactation delay and when it is infrequent, very important, exclusive breastfeeding. Then we have to be checking pre-discharge bilirubin levels. Are we all routinely doing pre-discharge bilirubin levels? So those are all what have been instituted, because even in the high-income countries, when these babies are discharged home, they even go home with the transcutaneous bilirubinometer, and the mothers are taught how to do it, and the health worker goes to check to be sure that all is well, and then counseling these mothers when they go home. This is a sad picture of a baby who already has features of acute bilirubin encephalopathy with all the retrocolis, with all the opistotonus, and the high tone, the hypertonia that the child has with some scissoring. Okay, cephalhematoma. Babies of infant of diabetic mothers that have polycythemia, family history of neonatal jaundice. Okay, so what are the outcomes? You can have jaundice, you can have acute bilirubin encephalopathy. Those are the presentation in the acute period, acute bilirubin encephalopathy, a lot of the babies that come to us. But then when you have the permanent neuronal damage, it's kernicterus. So because earlier, it's like those two terminologies were interchangeable. No, they're not interchangeable. Acute bilirubin encephalopathy, most of the babies within that first acute period, first month, they have acute bilirubin encephalopathy. But chronically, when they're now coming beyond the neonatal period, that's when we utilize the terminology kernicterus. So this is what has been described here. This refers to the, ABE refers to the acute early manifestation, whereas kernicterus is retained for permanent clinical sequelae. And, but very old textbooks will actually talk about kernicterus as seeing the pathological diagnosis, meaning that you're seeing the brain, corpse section in the pathology, in the morbid, and you're seeing the staining, the yellow staining of the basal ganglia. But this has been more like harmonized. So to also know that it's not just the basal ganglia that's bilirubin. When it crosses the blood-brain barrier, it's not just the basal ganglia. It affects the cranial nerves, the cochlea, that's why they're having problem with hearing. Oculomotor, that's why they have paralysis with upward gaze. Cerebellar nuclei, that's why they're having problem with balance. Those babies, they have chorioauditory cerebral palsy. That's the brainstem nuclei, hippocampus, and also the anterior horn cells. So it's a lot of damage. And for us to know that bilirubin toxicity is from unconjugated bilirubin, it actually causes death of the brain cells, apoptosis, necrosis of the brain tissue. And then this will now lead to the bilirubin-induced neurological dysfunction. And then to break down the acute bilirubin encephalopathy, we actually meant to recognize this in the early phase. There are three phases: early, intermediate phase, and the advanced phase. Early phase, the first sign is lethargy, which at this time is, is this sepsis, but any lethargic child, subtle signs, lethargy, hypotonia, high-pitched cry, poor suck. And then the intermediate phase, from this, if we miss it at this point, we have the intermediate where the baby is now hypertonic, like we showed in some of those pictures, opistotonus, retrocolis, irritability, oculogary crisis, actually what has been described by Slosher et al. As kernicteric fascia, all right? Then they will be having seizures. Advanced phase, you now have pronounced opistotonus and retrocolis, weak and shrill cry, high-pitched cry due to cerebellar irritation, then apnea, seizures, and the baby can be comatose. So this is like the kernicteric features. This is a publication by Slosher et al. Paralysis of upward gaze. The baby is staring, just have a staring look. Eye retraction, facial dystonia, disconjugate gaze because of affectation of the oculomotor nerves. So now these are all new additions. How we assessing this baby using the bilirubin-induced neurological score. So ABE can be evaluated, and we see that the higher the score, the more the affectation of the cerebral central nervous system in these children. We're looking at the mental status, muscle tone, cry pattern. All this will be shared so that we'll use them routinely, because we use routinely evaluating these babies when they are referred to us in the jaundice clinic. So we're having that mild acute bilirubin encephalopathy is a score of 1 to 3. This baby is still having subtle signs of acute bilirubin encephalopathy. Moderate acute bilirubin encephalopathy, when the score is like 4 to 6, you now need urgent bilirubin. By the time the score is going beyond 3, you need to urgently do an HM blood transfusion. And if it is done early, when the score is just about 4 to 6, you can actually still reverse some of those complications that the baby is to have later, some of the acute damage. But when it is now severe, 7 to 9, it's more further damage of the brain had occurred at that point. Chronic, just to mention the chronic bilirubin encephalopathy, which is the kernicterus. When we're now seeing these babies later, choreoathetoid cerebral palsy, babies having windmilling movements, involuntary movements, dyskinetic cerebral palsy, partial or incomplete sensorineural deafness. That's why the hearing assessment must be integral part. And Dr. Lusoya has been doing so great in this area to check the hearing of these babies. And to know again that a lot of this hearing assessment, sensorineural deafness is seen more in the preterm babies because of immaturity. So being a preterm potentiates this baby to more complications. Paralysis of proper gaze, intellectual impairment. Usually with jaundice, you don't have major mental retardation like you have in asphyxia, but this child still has, it's like a brain boxed into a non-progressive motor function. So dental dysplasia, lots of hair we have noted sometimes. This is a slide to actually show that with the preterm babies, the risk of bilirubin neurotoxicity is much, much higher, and their buying scores, so we have to be monitoring. Start early phototherapy in the preterm babies because they have lower albumin. All the factors are actually against the preterm babies. The lower binding capacity of the albumin is even reduced. They have lower conjugation. They have lower function of the conjugating enzymes, etc. So now, for us to have more discussion, what can we do? We've gotten all the following, the outline from the lecture. We had the case scenario. We looked at the principles. We understood the physiology. How can we now prevent? What can we do to these babies? Because they are all over, multiple, So we have to anticipate and institute preventive measures. We have to create awareness about dangers and prevention of jaundice pre-pregnancy. What are we telling young adolescent girls in school? Have they heard about jaundice? How are we going to integrate this even before they get pregnant? Now, education of mothers and families and healthcare providers. From antenatal, we'll talk about this. We'll have pictures of babies whose brains were damaged. I know Dr. Ezeaka here had this program. A lot of health promotion is going on around if it is that mothers are counseled from antenatal for them to understand. And then when they're being discharged, they also talk about jaundice. Then the need for them to be followed up, that will reduce significantly a lot of the problems we have around jaundice. Then if health workers understand that it's not all jaundice that is physiologic. So these are all the factors. Do we have a point of care? These are all the new things that we want to talk about or to add to this presentation today, that we have a point of care machine that is now available. All right, so screen, and then talking about mass education, the Neonatal Society actually had this one-pager leaflet that talks about take your baby to the health center within 3 to 5 days of delivery. So still working with the Federal Ministry of Health to get this into the national routine for primary healthcare centers. Because if it is that they go to be checked by 3rd to 5th day, because that is the peak, we will save a lot of brains of our babies. We have to routinely screen mothers for ABO and rhesus. They even tell us, that they check the rhesus, they don't check the rhesus routinely sometimes. And even in some of the big facilities, by the time you're getting the results, the mother had already delivered the baby. It is when she now has the jaundice, the baby has the jaundice, that you're tracing, and they are now being told, oh, mother is rhesus negative. So we have to tie together a lot of gaps to prevent this severe damage we're having to our babies. Promote and support exclusive, early and exclusive breastfeeding, routine examination of all newborns within 24 hours of birth, 48 to 72 hours, and 3 to 5 days, Then we must give pre-discharge counseling on neonatal jaundice, and pre-discharge screening. So the transcutaneous bilirubinometer, do we have it to use to screen these babies before they go home? Prompt intervention, underlying causes, reducing serum bilirubin to prevent ABE, and then monitoring the central nervous system. These are all principles of management. So the underlying, what are the ways we can treat these babies? We talked about careful assessment, observation, close monitoring, visual assessment, the Kramer staging. But this Kramer staging is still very subjective, especially to one who is not very diverse, who is not very experienced, who does not do it every day. And in very dark babies, it may actually be difficult to pick that jaundice. Blood level monitoring, interpretation of risk levels and need for treatment, meaning that we should be monitoring these babies before they go home, and then be able to interpret it using the pre-discharge charts. Phototherapy, we'll talk more about phototherapy, but for intensive phototherapy, we have to aim for at least, because when we say intensive phototherapy, using the light meter, we have to give more than 30 microwatts per centimeter per nanometer. Exchange blood transfusion, other therapies, immunoglobulins, increased conjugation. We'll talk about that. There's some research work coming more from Asia on the use of intravenous phenobarbital, but we'll still talk about this to say it's still in the experimental stages and has not been, for routine use. Decreasing enterohepatic circulation using agar, cholestyramine, zinc, inhibiting bilirubin production, inhibiting that rate-limiting step, heme oxygenase, using metallopurpurins. These have been all tried, but bilirubin, it is when it is severe that it is toxic. But bilirubin is actually needed for normal metabolism in the body. It's an antioxidant. But it is now when it is much, when it's a lot, and then when there are factors that will break it from albumin, that's when it gets to the brain to damage the baby. So you can bind the entire heme oxygenase so that you won't have bilirubin production at all. This we have mentioned, and this we all see in the text, but to say that the key thing beyond this Kramer chart, where bilirubin goes from cephalo to caudal progression, we've tried to find out why should we say cephalocaudal progression. And some of the reasons being proposed is due to the diminished capillary, in the function in the distal part of the newborn. That's why you're having it centrally, and then you're getting to the periphery. So when you're having bilirubin just around the head and neck, it is level 1, where you're saying it's about 4 to 8. These are estimates. By the time it's in the upper trunk, it is 5 to 12. And the time it's getting to the lower trunk, it is 16. And by the time it is number 4, getting to the arms, it is up to 11 to 18. However, anytime you're seeing bilirubin, they're seeing jaundice, sole of the feet, these are 5. And the palms know that it is above 18. So these are rough estimates. So we've talked about the transcutaneous bilirubinometer. This is a non-invasive equipment that we should all have to screen these babies, and then to also use it pre-discharge, and then for centers that can actually afford to have one that the mothers can go for monitoring, especially when the mothers may not routinely come to the hospital. That can also be used. And then a home visitor can actually use it like they do in developed countries. A home visitor can use it to actually go to the homes of the mothers who have been discharged, just to be sure that this bilirubin level, that the jaundice is not going beyond the physiologic range. for the babies. So this is a transcutaneous bilirubin hour nomogram. These are some charts that can be utilized, and we have some of these charts in our comprehensive newborn care guidelines. I had mentioned that there is now a point of care bilirubin testing machine, because the whole essence earlier, the whole challenge was you take a bilirubin sample now and you're getting the results, maybe tomorrow, in some mainstream, in some centers, you know. And by then, of course, within 30 minutes, it's no more representative of what the picture of the baby is. So we need a point of care machine. So the program, the Newborn Essential Solutions and Technology Next 360 program, validated a point of care bilirubin testing, which actually the launching is ongoing across the 2 countries, Nigeria, Kenya, Malawi, where the testing was done. And we are hoping that, you know, it's being planned that by this June, we've done the testing in Lutz. By this June, the equipment will be in Nigeria for commercial distribution. And the distributive partner of NEST, JNCI, will be able to coordinate those. But to say it is available now, and it's all being distributed, coming into the countries. Actually, there was a picture today where they launched it in Kenya. Then it enables clinicians to measure serum bilirubin at the bedside. It's a handheld device with a disposable strip, and you use it just like a drop of blood, just like we do the glucometer. You don't need to centrifuge like we use in the bigger bilirubinometers. And it's scheduled for rollout, national rollout from this June 2022. So to move quickly, this is all the talking about phototherapy and HTM blood transfusion. But this is to say, what is the mechanism of action of phototherapy and which is the best light to use, or the physiology, to say that the phototherapy, the light that comes from phototherapy is a drug, and we have to measure it. And research has shown, okay, the mechanisms of action. It can cause structural, you know, it can change the structure of the bilirubin, or it can give some isomerization, or it can cause some photooxidation. But the lying factor that phototherapy does is that it breaks down this fat soluble bilirubin to make it to be water soluble, so that it can now be excreted in the stool and in the urine. And if you follow this graph of colors, you see that the maximum point of absorption of bilirubin is at the blue light, within the 460 to 490 nanometer range. So the maximal spectral absorption of light. So the blue light is preferred over the fluorescent light, but now the LED lights are the most preferred. And then we should also use charts and guidelines for determine when a baby should be for phototherapy based on the age of the baby and the phototherapy level. One key thing that we should learn is that for the high-risk babies, these are babies that have low albumin, babies that are acidated, acidotic, hypoglycemic ill babies, use the lower line. But for the babies who are not high risk, you can use the lines that are the third line is utilized. One other thing that we should learn about using of the chart is well stated that please use the total bilirubin. Don't do subtraction. You know, before we say, oh, let us subtract the conjugated fraction from the unconjugated fraction. It's stated here, use the total bilirubin, because you want to, most times the conjugated fraction is not marked for most of these babies. So now for effective phototherapy, we are looking at the distance, 10 to 15 centimeter. It's not before, like in regular tests when they will say, oh, up to 45 to 50 cm. With more advancements in teaching and in clinical service, we're now saying 10 to 15 cm. And you actually see when you use the radiometer that by the time you're coming closer to going away from the light, the intensity of the radiance is decreasing. There was a time we used the radiometer to test some fluorescent phototherapy lamps across. We're even getting less than 1. You won't believe that we actually got 0.5, 0.2 from phototherapy lamp, because maybe out of 5 bulbs or so, only 2 will be on. Whereas with the newer phototherapy machines, LED, you're getting 60 microwatts, 60 microwatts. And with this, we don't need all the EBTs that we used to do, 5 EBTs in one night. The rate of HM blood transfusion is drastically reduced if we have effective phototherapy. We can aim for double surface phototherapy, maybe have baby lying on a billy blanket and then have a phototherapy above. And then you also know that we see that if you use a white cloth in the cot of the baby, it radiates the light towards the baby. So every baby on phototherapy should be on a white bed sheet, because that brings the light to the center, to where the baby is. Moving quickly now, then we have to change the bulbs. Clinical notes is that every facility should have a transcript, aim to have a transcutaneous bilirubinometer. And then the point of care, once available, aim to have a point of care diagnostic equipment, because that delay in getting the bilirubin results is another key challenge that we have. And then centers to have radiometers to measure irradiance, because you can't just be giving medication to a baby and you don't know what you're giving. And then you have to prescribe. You say commence phototherapy at conventional, intensive if it is that the bilirubin is, but when it is now, the bilirubin level is now coming down, we reduce the setting to the conventional. The conventional is like you're looking at 10 to 30, but for intensive phototherapy, it has to be above 30 microwatts. Then we have to turn the baby regularly, every 2 to 4 hours. Not many of us remember, that this baby has to be turned. There's some research work that actually showed that keeping the baby just on one side, on one side, that at the end of the day, you just expose only 35% of that baby. And this is also to add about the diaper. You look at a preterm baby is wearing diapers, it has covered up to the chest of the child. Remember that the phototherapy you're giving is a drug, and it is acting on the skin to break unconjugated bilirubin down to make it water soluble. Then ensure that the baby is at the center of the phototherapy machine. Monitor the hydration. Make allowance for 20%, 20 mils per kg extra when the baby is under phototherapy. Institute measures to maximize the phototherapy administration. The distance, you have to measure the distance. Sometimes we now have to use an extra mattress actually to bring the baby a little higher up, so that the distance from the light is better. And with the LED lights, you're not, the fear of overheating the baby is reduced to minimum, and then to use white sheet rather than the mother's wrappers. These are quizzes that sometimes we show, but these are key things. You look at these babies, if you look at A, look at B, look at C, look at D, there's big deficiency. These are not effective phototherapy, and these slides thanks to Professor Tina Slusher, who has done lots of work on jaundice. These slides, I remember, we're trying to use these quizzes at a teaching session. So you see 2 babies here. The light is only on one baby. It's not touching the other child. So the jaundice will still keep progressing, and we'll have baby have bilirubin encephalopathy. And this happens. This bulb just has only 2. And then they'll come and tell you, this baby has been receiving phototherapy, has been under the lights. And you're looking at a child who has active bilirubin encephalopathy. How effective was the bilirubin, was the phototherapy that you were giving? So out of maybe even sometimes when there are 3, 4 bulbs, you see it's only one that is on, all right? So, and then look at the distance again. Look at the height of the phototherapy down to where the baby, we can't even see the baby at this distance. 3 babies, the light is just on the one in the middle. And we shouldn't keep these babies together, because as they're sharing phototherapy, they're also sharing infections. Now, see again how high this is, and see how low where the baby is. This is more than, this is way not correct, because we are talking about 10 to 15 centimeters. This is more than more than 150 centimeters actually. See where the baby is, you know. So these babies will not get well. Their brain will get damaged. Well, rounding up to talk about some other in the newer terminology, you know, newer therapeutic options, just to give an idea of how just changing the distance of the baby can increase the irradiance. So we have here a chart that shows what is the measured irradiance. You know, this irradiance has to, you know, you put a baby under the light. It's like, it is the irradiance. So these light meters, they're available. They're available in the country for us to use for effective management of even the jaundice babies that come to us. So the blue shows with this, there's 6 bulbs with this phototherapy light and for these babies. So the blue shows the irradiance with the 6 bulbs, with the baby being 15 centimeters from the patient, but there was no white sheets. And we can see that the irradiance was 13.6. However, the same 6 bulbs, the baby 16 centimeters for the red one, just placing a white sheet for that baby increased that irradiance up to 16.2 microwatts. But then look at the one that has gone up to 23.3 irradiance. 6 bulbs, the distance was now reduced from 15 centimeters to 10 centimeters. And then a white sheet is placed for that baby. That now shot up the irradiance to 23.3 microwatts. So of course, this will give more effective phototherapy, just with little adjustments. We should also remember that phototherapy is a drug and it has side effects. So the side effects, the dehydration, hypocalcemia has been mentioned. You know, hypocalcemia has been mentioned that it can affect the pineal gland in the pituitary. We can have rashes, brown baby syndrome, hemolysis. So we have to be cautious. You know, if the baby doesn't need phototherapy, maybe it's not to get it. And then we should be monitoring to know when the baby has to come out of the phototherapy machine. Retinal injury, and then these are acute. You mentioned prolonged, we have vitamin B12 deficiency had been mentioned. And then later, some allergy, DNA damage, that's why we're covering the testes of these babies, tumors, etc. So know that it's a drug and we should monitor. Make it effective, reduce it when the baby does not need. But the key thing is that it must be prescribed, it must be monitored. Add more, reduce the dehydration, add more hydration. We can't finish talking about phototherapy without talking about sunlight exposure, because every mother knows, to say sunlight. So what are their safety concerns around sunlight, including exposure to harmful ultraviolet lights? Because with the sun, it comes with the UVA rays A and B, which are harmful. Risk of skin cancers, potential sunburn, thermal effects. And then we've had indigenous studies done in our country that shows that filtered sunlight can actually work in sub-Saharan Africa with effective monitoring to shield off this harmful sunlight ultraviolet rays. And this study is a landmark study that was done by our own Dr. Lusanya that is on this platform, and Professor Tina Slosher. And it had been tried, but this is their tent that was put up in Lagos. And it showed that these babies, 92% of them, or 92% effective as standard phototherapy. Some of the babies were the ones that just had some thermal issues that had to be brought out because but no key complication around overheating, because they were monitoring the temperatures of these babies round the clock. So this is a very landmark study that shows that with appropriate monitoring, filtered sunlight phototherapy is an effective alternative. So when we don't say sunlight, we have to qualify it. Filtered sunlight phototherapy. So having said all this, that these equipment are available, we'll talk about the newborn essential solutions and technology, innovative technologies, which are available in Nigeria currently. This is the Billy DX, it's a Federal Ministry of Health program. And the phototherapy machine that is with the Newborn Essential Solutions and Technology Program comes with an attached light meter. It's attached to it, and it's available with the program. This is an oxygen concentrator that can split oxygen to like 8 to 10 babies, yes, from one oxygen concentrator. This is the bubble CPAP. So we're talking about these technologies. How is it going to help? Because the babies who also join this, some of them are preterm, they need phototherapy, they need radiant warmer, they need bubble CPAP, they need oxygen, etc. Because we're looking at comprehensive care of these babies. Asian transfusion, we're trying to reduce as much as possible. But if Asian blood transfusion is to be done, aim for it to be done as quickly, as promptly as possible. And then we use nomograms. Also, using nomograms reduces, using the nomograms again, we have to know for the high-risk babies, use the lower center. Like if these babies have G6PD deficiency, if it is ABO, if it is acidotic and preterm baby, use the lower center for as a guide. Other modalities of neonatal jaundice treatment, we talked about intravenous phenobarbital as an inducer of hepatic bilirubin metabolism. We mentioned this because I've listened to some presentations from Asia, and it's like, oh, baby was giving IV phenobarb 5 milligrams per kg per day for 5 days, for severe jaundice. But we know before that to say, oh, this is for Crigler-Najjar syndrome type 2 to be used to activate the bilirubin conjugating enzyme that is defective. Several studies are showing that it's effective in reducing the mean serum bilirubin values in the first week of life. It can also be administered prenatally to the mother. So this is just to say that these studies are evolving. And towards the later end, it says that we have to, in populations in which the incidence of neonatal jaundice or kernicterus is high, this type of pharmacological treatment may be considered. It is not routine. And then to show that, however, concerns surround the long-term effect of phenobarb on in these children. So we'll talk about it and to say, let us follow the path of early detection, prompt intervention, and early treatment, rather than giving. And we also need the side effect of giving phenobarb sedation. This baby is sedated, you'll not even be able to clinically assess the central nervous system status of this child. So it says, therefore, this treatment is probably not justified in populations with a low incidence of severe neonatal jaundice. This was mentioned because in routine presentation, they said that these babies had IV phenobarb. Another modality that's also being utilized is oral usodiol. This is ursodeoxycholic acid. It's called UDCA, which originally was more like for cholestatic jaundice, using to help to flush out the bile. But it's now occasionally being used as an adjunct additive to phototherapy to help to induce bile flow. And, because with more bile flow, with more washing away of bilirubin with the meconium as stechobilirinogen, it reduces the enterohepatic circulation. So it's given orally, at the dose of, most would say, well, there are even trials to say, is it 7.5 milligram per kg per day, or is it 10 milligram per kg? These are all still experimental. Further studies are needed, so they are not yet routine. And then the studies that use the UDCA were all little numbers. In Egypt, they tried in about 100 babies. So they're saying that they still need wide-scale testing of this phenobarb UDCA, because in those presentations with the Asian teams, baby receive IV phenobarb, baby receive oral UDCA, and it's like, these are not routine for us in our country. So we still need to do in-house research works for us to justify routine use of this. And even the literature says we need to be careful because of long-term effects. Again, UDCA was actually said to reduce some degree of blood-brain barrier penetration. by the unconjugated bilirubin. So this is an area, they're actually trying to follow, and the fact that it's given orally, can it really have all those effects significantly? So decreasing enterohepatic circulation using agar, cholestyramine, zinc, actually said to be still controversial. And randomized studies show significant reduction. But the use of zinc had actually resulted in shorter duration of phototherapy. So most of these therapies are added to phototherapy, like the oral UDCA tended to reduce the number of days a baby will be on phototherapy, etc. Then the not for routine use. Another one that's occasionally common is probiotics. That when we have babies giving probiotics, they colonize the intestinal lumen and reduce the overgrowth of the harmful bacteria that tends to cause more of the deconjugation. And again, the probiotics help to follow up on monitoring of this baby. Neurodevelopmental assessment is very important. Any child that has been treated for jaundice, EBT at the age of 1 month, 3 months, 6 months, 1 year, and processing, language development, clinical exam, CNS wise. So what are the products? We see CC. This child is deaf. And this is what we see with acute bilirubin encephalopathy kernicterus. She has chorioauditory cerebral palsy. She cannot walk. She cannot talk. She cannot talk because she cannot hear. But she can think. Like we have said that with bilirubin encephalopathy, the mentation is not as severe. They don't have mental retardation, severe retardation, with like babies that have severe asphyxia. She had acute bilirubin encephalopathy and has kernicterus, of which there is no cure, only clout. A lot of what have been in this literature that the country now has national guidelines for comprehensive newborn care, looking at these babies that have joined the context of the Federal Ministry of Health-led program. We've been running a lot of essential newborn care, respiratory support, helping babies breathe, breastfeeding, hand washing, but not much of advanced care. So this is another level. We're moving, strengthening essential newborn care, but adding comprehensive newborn care as a national initiative. So this is the national guidelines, which will also be posted on the site. It's already on the Federal Ministry of Health website, and in November 2021. So this is a plus for us, because all the while, all these babies that have jaundice, asphyxia, seizures, we just say refer, prematurity refer with the essential newborn care training. But when you say refer, what harmonized protocol, what training have we given all our doctors, all our nurses, all our biomedical engineers on how to manage these babies? So thank you, and the key message is jaundice being a major public health concern. Unconjugated hyperbilirubinemia is a significant cause of morbidity and mortality. Awareness creation to start from pre-pregnancy, so we have to have advocacy, awareness, enlightenment campaign, pre-pregnancy in schools, adolescent girls, antenatal clinics, education of both mothers and healthcare providers. Establish protocols, utilize the protocols that are available currently. Newer technologies, LED phototherapy, irradiance meters, transcutaneous meters, point of care bilirubin meters are all available. They're all available for us as a country. It's for us to utilize them. Then we have to interpret the bilirubin levels using standard charts. Aim to have pre-discharge bilirubin estimation and post-discharge counseling. We must talk to every mother who is being discharged, and then have routine follow-up being imperative to know that newer options, IV phenobarb, oral UDCA, Udacel, still not widely advocated. More research, more participants need to be needed. But with all this, kernicterus must be prevented in all cases. Thank you very much. Sorry, I hope it wasn't too long. Thank you for your kind attention. Thank you.
They said 1.8. I said, which baby? And all of you looked at this baby.
Thank you so much for your listening and for your time.
Thank you very much, Professor, for that very impressive discussion on jaundice. You took us through the pathogenesis. You also took us through clinical features of, when damage does occur, which is a sad thing about jaundice, is the baby just lies there getting darker and darker, and more yellow till the bilirubin starts. You've educated us on the acute and the chronic, early acute, it progresses to the chronic. You brought a very important point, which is the cultural considerations, because I think this is really affecting our service, our operations, our home therapy for jaundice. And within this context, you have called for advocacy and awareness. Advocacy to people who can make change, and awareness to the general public through all the different media possibilities that we have now. We've talked a lot about our monitoring of jaundice, and I'm very happy you have mentioned about preterm babies, because I have always thought that might be a weak spot for us. Many of us have taken on preterm babies, the very low birth weight, and jaundice in them is very subtle. And while we are still trying to deal with the RDS or sepsis or IVH, the jaundice creeps in, and before our machines are able to count it, to measure the level, it's already exceeded the danger level. So you've told us about nomogram charts, and I hope all of us know that they have different nomogram charts for babies of different gestational age. We have them for the babies who are less than 28 weeks. You've given us a lot of guidance on things that we can change, from simple things to education during the antenatal. I think it's very necessary for us to have a no to jaundice program. We had one like 11 years in my organization, and we really changed the learning and the pre-input evaluation. We found that only 58% of mothers knew that jaundice in babies is dangerous. So the people are out there and they don't know jaundice is dangerous. So I think this discussion should be the beginning of change for us private pediatricians. I'm happy that Dr. Ezeaka is interfacing with us, because I think it's about time the public and the private started working as one when it comes to very important issues involving our newborns. Because once damage is there, you can't revert backwards. This is one area that we just have to have a good marriage in creating change. So thank you. So I won't end up giving my own lecture again on a topic that's so dear to me. Thank you, Professor, for this very good and very detailed discussion. And I'm sure everybody has learned some new things. So I think it's time for questions now, so that what our last 60 participants, what we think and how we can make a change. because knowledge is good, but it's only relevant when it's making a change in our society. So, do we have any questions? Let's see, chance. Is there anyone raising their hand?
Yes,
Yeah,
I'm raising my hand.
I have a question. Hello.
Yes, who is this?
Yeah.
Please just introduce yourself.
Yeah,
And then-
Nkyuka Suma from Pelham Memorial Hospital. My question actually is more of a practical one. And first of all, let me commend Lolo. I mean, I didn't expect anything less. Her presentation was brilliant. She covered practically everything. She already answered some of the questions I wanted to ask. But this has to do with the first-time mothers who are really anxious and they're not making enough. Really is, yes, what I believe that breast milk really is the best, and it's is the best for the mother. What does one now do when you know the child is jaundiced? Where do you now say, okay, fine, can we, like, after each breast milk, give 5 or 10 mils of breast milk substitute while the mother is trying to adjust so that the baby doesn't get that enterohepatic circulation is not now further worsened with because the baby is literally starving, in quotes. I don't want to use breastfeeding jaundice. I rather use starvation jaundice. So what's your take on it, Lon?
Okay, thank you very much. Thanks so much, Sister Dr. Suma. Dr. Ezeaka, are we to take each of the questions, or we can have some and then answer them, and then what do you think?
I think it's better. I prefer when you take it just fresh, immediately it's said, when we're all still thinking, you give us the right answer.
Okay, all right, thank you so much. Yeah, so, Dr. Suma, even when you were putting the question, you said when the mother is still resting, we actually tend to maybe give a lot of leeway for these mothers. That if it is during antenatal, and then before she even delivers the baby, she knows that within 1 hour of delivery, she's putting the baby to breast.
Yeah.
So, and this has been shown that that's early initiation. We don't do that. Within 1 hour, we don't do that. So when she's
we do. Sorry to interrupt you. We do, and most of our patients do. But you still get that odd 1 or 2, and there's so much pressure. Sometimes they even come with their milk themselves. They come with the milk already ready. Do you understand? So I'm just saying that.
Fantastic. Fantastic that you do it routinely. And like you said, just 1 hour. There may be some outliers. And of course, you can't allow the baby to starve. But most centers, they don't even try that within 1 hour.
Okay, fair enough.
It's
I just wanted
to exactly.
Because I mean,
yes.
No, I'm just saying sometimes
there's a graph.
Practical aspects of breastfeeding takes a lot of commitment from the mother,
exactly,
a lot of counseling. And do we now have that? Do we all have that time? Do we have lactation consultants? I mean, lactation, what do you call them anyway? That sits down.
The lactation consultants.
Yes, that they help the mothers, especially first timers who already have family around them that saying that you can't do it and it's not enough. Give this, give that. So if we have, there's a lot of pressure then. So my point is, I just wanted to know your thoughts, and you've already said that, well, maybe 1 or 2, but it does happen.
Yes.
Okay.
Thank you so much. Yes, for most mothers, if you start early, that's early initiation, and then start feeding the baby every 2 to 3 hours, even at night, you see that within 24, 48 hours, both of them have settled in and the breast milk is flowing. There's a chart that shows that just a mother starting breastfeeding early, you see that by the end of the week, she's producing about 350 mils. Meanwhile, another mother starting breastfeeding just within 12 hours, that late initiation. And then you see that by 1 week, she's still struggling to make 100 to 150 mils of breast milk. So that is to say that let all of us promote the early initiation exclusive. But that is not to say that there may not be some outliers, one or two mothers, due to peculiarities, due to their own comorbidities, that they are not able to do all that. Then, of course, we help them with breast milk substitute, and that's what it is. But rather than across board, we're not trying, like occurs in some centers. But if it is that breastfeeding is given, that's starvation. You see a lot of babies being brought from the lying-in wards back to neonatal unit to receive phototherapy. It's all due to that increased enterohepatic circulation, due to that physiology that we have explained. And to say that there's a lot of those increased numbers of those beta-glucuronidases that are there to deconjugate the bilirubin, immediately there is no peristalsis with stool and with feeding to wash it out. It goes back as unconjugated bilirubin and will cause kernicterus, cause acute bilirubin encephalopathy for the baby. So that feeding is critically important if we are to reduce the large numbers of babies that are coming with jaundice by 3rd day, 4th day, 5th day. Thank you so much.
Yeah. Hello, this is Daya Jaibe. I'm coming from the UK.
Thank you, Dr. Daya.
How are you?
Thank you.
Congratulations.
Thank you.
Excellent presentation and very
Thank
detailed.
you,
ma'am. I have a couple of questions. Number one, in terms of what is the incidence of neonatal jaundice now in terms of kernicterus? I remember the days when I was in Luth, we'd exchange on every shift 5 a night with exchange. Is this still the problem? Of course, because all the poverty in the country, people are not delivering the hospital anymore. What's the impact? It might not be Luth. Are they going somewhere else and having babies and becoming kernicteric? What is the situation in Nigeria as a whole? That's one.
Okay.
Number two, the cost of bilirubin that you're talking about, what is the cost? I hear you talk about strips. How much is that strip cost? Is it affordable for the parents? The other thing I wanted to know, what are the current challenges with this whole program? So logistics, mothers are discharged, when are they discharged? I mean, in the UK, okay, I've given an example of my own hospital now. It's a conveyor belt. So most mothers are discharged within 24 hours, some within 6 hours if they've had babies before, they just discharge because it's a conveyor belt, there's fewer beds. So if you're discharged within 24 hours, how is the follow-up process? First 24 hours, if neonatal jaundice appears within 48 hours, it is pathological. Jaundice checks being done. Are these ones going to return? Because by day 5, many of them, one's going to be kernicteric, are going to be kernicteric by day 5. I mean, we have a community program. Now, I know it's very expensive, but I just wonder, I like the idea of you talking about the education. It's very important, and mothers being aware. But are we picking up, is there a study going on? Okay, mothers are aware, if you do the jaundice level, is it within normal limits? How many are being missed? So I'm just wondering, what's the impact of the educational program? And is it, I think it's very good, but we should be measuring the impact. Another one, the umbrella, the filtered sunlight that Dr. Lusonya did studies on. Why haven't we taken it forward and given mothers umbrellas with these filtered light filters? So mothers can actually hold these umbrellas or put on their child in the sunlight. That might be an effective way, cheap enough for the average person in the village to use. Another thing about the solar phototherapy, there's no light in Nigeria. Is there solar phototherapy around? I'm sorry, I'm asking lots of questions. I'm really sorry. And then finally, in terms of neonatal jaundice and management, I think what Dr. Asma mentioned is, when you look at neonatal jaundice, it's a medical emergency. So when you have these babies coming, I mean, I've only done one exchange blood transfusion. I know we live in different societies in England. I've only done one, and I was called to do it because nobody could do it. Most of them, even if they're the line with exchange blood transfusion, we put 4 times phototherapy on, and then we actually now feed them because of dehydration. We feed them. So we breastfeed, mom's milk is not enough. We give them milk we put NG tube through to crash it down. Because exchange blood transfusions have their risks in terms of all the blood-borne infections and all the rest. So just these are some of the, some questions that some of the comments and questions I just wanted to ask.
Thank you
Sorry,
so much, Dr. Joy. Yeah.
Dayo has so many questions. She should come back home to make change.
I'm sorry. No, I'm sorry. I apologize. Just, I mean, I just.
Yeah, so those are all the challenges we're all grappling with. It's like, oh, you're putting them all together, because initially there was even like not an entire harmonized protocol. Your first question was the prevalence of
the incident
bilirubin. Yes, yeah, in Lutz. You know, during the presentation, I had actually mentioned that initially it was like we're having like 5 EBTs per night. Maybe you'll come and say I had 5 exchange blood transfusions, but they've actually reduced. And like you said, well enough, are they going somewhere else? And we must also again remember that with Lagos State, earlier in those days where you people were, you know, when you were all in country, that Lutz was the ultimate referral. But within Lagos State now, we have mother and child hospitals across every local government area that have pediatricians. So our pediatricians are also going to other centers. So it's not as much. Sometimes now we have maybe 2-3 a week. Yeah, maybe about 2-3 a week. One every other night. That sometimes you're even giving lecture to medical students and you're saying, how many of you have watched exchange blood transfusion? And some will raise their hands and some will say they did not say. So it's not as it was before. But sometimes again, they come in crops, you know. So are they coming from certain centers? So that's why the awareness creation, the teaching, the prevention, and not only this awareness, it has to be in the local language. You know, it has to be in the local languages. It has to go on the radio. It has to be on the media. So many of us, as we are, we can actually organize ourselves into, you know, keep having this discussion with Dr. Teko. Organize ourselves in social media. How many times with all the social media things that we're saying, have we talked about, oh, this jaundice, it can. So we can utilize many other avenues now to spread this awareness. Print, electronic, push out this information, have a baby who has brain damage, and let mothers know. So there are many ways we can create this awareness. Bilirubin discharge within 24 hours. Yes, like you said, that this is a mother who have delivered babies before. The thing about this monitoring is you have a pre-discharge monitoring, but you have the counseling. You know, when you counsel this mother, watch, you know, to check. And again, like in your center, you have home visitors that will go to monitor these mothers and babies. You're not just monitoring the baby, you're also monitoring the mother. Remember that this mother, some of them can have postpartum bleeding, some of them can have raised blood pressure, some of them can have postpartum depression. So postnatal care is part of our essential newborn care training, that you can't just discharge a mother and a baby, whether it's 6 hours, whether it's 12 hours, whether it's 24 hours. You have to counsel them, and then there must be postnatal visits from day 2, day 3, day 5, day 7. And if it's a preterm baby, you have more follow-up. Because remember again that this jaundice, the preterm, almost 80 to 100% of preterm babies will have jaundice. We shouldn't forget. Now you talked about the tent, you know, the tent filtered sunlight. Yeah, you described it as an umbrella. You know, we still have to monitor this baby. It's not just the mother carrying the umbrella and moving around. But I wouldn't know if Dr. Lusaya is in this, because I mentioned, to remind her, you know, whether she's here, she was part of the study, and Professor Tina Slusher. So it's also something that can get back to them. But they had a tent. And in that tent, it was noted that these babies were closely monitored because the irradiance was also quite high. It was also as high as 50, 60, 70. It was intensive, even from the lights. But you know, again, that it depends on the weather. you know. So it's not every time, even in the temperate countries, that you have the entire sun. Sometimes and that relates also to the solar. Sometimes the sun is not there if it rains, so that may still affect the, you know, sustainability of what you are speaking about. I totally agree with you about feeding them triple, because we even talk about double. I know, like in the high income countries, you put these babies on triple phototherapy. Baby is lying on a billy blanket. You have one phototherapy light by the side. You have another phototherapy light above the child. Triple phototherapy. By the time this hits the child from every angle. And then the baby has to be naked. You know, and people don't even realize this baby has to be naked. Then this light is on the skin, because you're putting on those lights and baby is wearing the diapers that has gotten to the chest. You know, so what are you doing? The phototherapy will not work. And by the time you're hitting this baby with light from all angles, not only putting the milk by NG tube, sometimes they even go ahead and setting an IV line for that baby, because that time you're worried about significant dehydration. All right. I think I covered some of those. Maybe if I missed
You didn't talk about the
some of
solar.
them.
You did talk about
Yes,
solar.
I said the solar. Yes, I said the solar phototherapy. Yes, solar. This is very important. Solar may be affected by light, but to say that there are also some studies now, some homemade research works around, that is the way a lot of this equipment will go. We know there's a colleague of ours, actually a University of Lagos master student by biomedical engineering that I supervised she devised a Billy bed, she even using solar. And then there's also another one that was posted on the Neonatal Society website where there's a Billy bed that's also mobile that can be, that can be used. So that is actually the way to go. So all of us integrating, not just clinical, but interfacing with the biomedical engineers, and that's part of the innovative arm of the Newborn Essential Solutions and Technology. So we're talking about solar, utilizing solar for a lot of this equipment. That other phonics, the phototherapy that I said comes with a radiometer, it's actually available with GenCI, but it's still electric based. But how are we going to how are we going to have the solar arms on a commercial basis? Then yes, you talk about the Billy DX, the strip. Yes, the strip, it's the cost. By the time it comes, even with the program, it's still less than $1. It will be quite affordable. And we're saying that it should be readily. And how can we even start producing the strips in the country? Because that's why we're...
Ezeaka, $1 is 500 and something naira.
No, right. So that's why I said...
And the average Nigerian earns $1.50. The average, the Nigerian in the village, they can't afford it.
Oh, yes, but those will still be, even for us now, even with the basic bilirubin testing, by the time a baby is jaundice, they still come to the hospital and they can't afford the bilirubin test that we do. We still use our discretion and even pay for the test. That's why the health insurance is another major, crucial aspect for us to speak about babies and mothers dying. Why don't we have sustainable, available, accessible health insurance for our mothers and babies?
But
right?
Ezeaka,
Because they come to the hospital, they have to pay. Yes.
I said, can we actually negotiate this price from the people who make it? If look at the costs, you need to Joneses and how much. You have to negotiate at the table that look at this price. It has to be low. By giving you you're producing because there's a market.
Yes. So all those are being taken into consideration. Yes.
I think there are so many questions to be asked about why we are failing in our prevention, curative, and rehabilitative area of natal jaundice. I propose that our organization or association of private practitioners reach out I put it to Dr. Mobolaji Lawal, my senior, that is about time we had a senior committee that would reach out to the different arms of government, the tertiary, secondary, primary care agencies, and even the traditional,
Yes,
and
see
traditional veterinary, and see whether we can develop. It might first start as a statewide conference where we are bringing the issues to fore. Because if you look at the statistics on the incidence of severe jaundice in different countries, you will see that our levels are much higher than other low-income countries. And I think it all starts from a lack of a good quality primary care system. And of course, health financing. So it's, is there access to care? There's also education, there's ignorance, and et cetera, but those are the basic things: poverty, ignorance, poor access to care, So I think this story is quite horrific. What is happening in Nigeria or in Black Africa. And why it's more frightening is that our skin is so dark that sometimes it hides the jaundice. So we are the ones that should really be clamoring for early detection and of course prevention, of course. So I put it to our chairman, Dr. Mobolaji Lawal, that this will be a wonderful initiative for us to bring some common sense to the handling of jaundice in babies, particularly using the primary care as the cornerstone or the foundation for reversing this trend.
Please, I've had my hand up. I don't know if I can ask my questions now.
Yes, please ask a question.
All right, thank you, everyone. My name is Dr. Ohuche from Niger Foundation Hospital, Enugu. I'd like to say a big thank you to Prof for this beautiful presentation. Just a few concerns. As medical students and residents, at least in the center where I was trained, we're taught that sunlight has very, very poor effectiveness in terms of managing kids with jaundice. And we actually, at least I came across a number of children who ended up with kernicterus supposedly because they were exposed to sunlight. So I've always, and then we were trained to discourage mothers and healthcare workers from telling mothers, to expose their kids to sunlight. But listening to today's presentation seems I've had the wrong information in that regard. So I just wanted clarification. Is this good practice? Is it okay for the mothers to expose their kids to sunlight, at least initially? So I just wanted clarification on that. And then secondly, madam, I don't know, I just wanted to share what we do in my center. I'm not a neonatologist, but then we have a neonatologist who has recommended that children with serum bilirubin of 10 milligrams per deciliter and above are admitted for phototherapy. And this seems to have reduced the number of children. I mean, we've hardly done exchange blood transfusions in the center where I work. So I want to know, is this an overkill? We just have a blanket figure. We don't have the charts available. I even want to know when we can get the nomograms, because currently it's not available where I work. And thank you very much, ma'am.
Thank you very much. Thank you, Dr. Huche, and very great, important concerns. So I've brought out this chart to say that sunlight exposure is a no-no. You don't tell mothers to keep their babies under the sunlight. Safety concerns, skin cancer, sunburn, thermal effects. But the most important thing is that these mothers, by the time they're putting their babies under the sun, they take it that they're psychologically treating those children. But in effect, they're not doing anything. So that delay is still potentiated. To say that sunlight exposure is a no-no, you don't put the baby under the light. But to say that there's this research, that was what followed the presentation, don't put baby under the light. But that there's this sunlight where there is filtered, there's a tent, it's a filtered tent, where you have something like, I remember it was like an X-ray film. It's a special filtered sunlight phototherapy research that has been done. I hope that is clear now. So it's not put baby under the light. Yes, it was a special filtered sunlight phototherapy. This was a big tent where you have the nurses and then you can see it was filtered. And this is not ordinary tent, it's not a house. You see that was, you know how the X-ray material is? It was a big special, because I know the team, Professor Hanks that came from the US, did that tent. It was a special tent done by the microbiology engineers, biomedical engineers, you know. It's a special tent that removed the UVA rays, the harmful rays, to say that, you know, because it will tell you, oh, sunlight, it is harmful. Don't put any baby under the sun. Don't advise any mother to sit under the sun. And it is not effective. That is even key. And then it takes the mother's strength and time in a way that, oh, she's sitting under the sun. Meanwhile, her baby will develop kernicterus. So sunlight is a no-no exposure. But in this part of the world, even listening to all the presentations across board, you just mentioned this special sunlight phototherapy. And one of the research teams is part of us in this platform, Dr. Lusoya, that has done so much work on phototherapy and done this. And now the 10 milligram per DL. You know, most of the charts will actually follow the baby's age and the baby's bilirubin level. Most will say, oh, for 10 babies, if it's about 10, start phototherapy. Then if it's about really 5%, you know, about 0.5, start phototherapy. But the thing is, most centers will still use about 10. Whereas if you look at the nomogram, if you really look at the nomogram, you see it's about 12 that you should start phototherapy. But to say that at any point, this is key, at any point that you're sure that this mother is not going to come back for you to check the bilirubin level, please keep this mother and monitor this level of jaundice, because it can be 10, then she'll go home. By the time she's coming, maybe in 2 days or 3 days time, the bilirubin maybe is now 25. So you have to always wait and then have unit protocols. How long are they staying? Should, you know, because most centers will aim to keep them for at least 48 to 72 hours, most, and etc. So always weigh that chance of baby coming back before telling them to go, and then keep monitoring. They just go, they don't just leave. Never you lose sight of any jaundice baby till you're sure that that baby is out of the woods. If she must go, tell this mother to come back. That's why for our center, we have a jaundice clinic. They don't even stay in the emergency room. They'll come to the jaundice clinic for this jaundice testing to be done. And that's what like is done in developed countries, where I say the mothers even go home with the transcutaneous bilirubinometer, or the health worker goes with the transcutaneous bilirubinometer every day to check, and so that you don't lose sight of that baby and mother till you're sure. One other person asked, when does the blood-brain barrier? Most babies, by the time you're getting to 10th day, the blood-brain barrier maturity has improved, because you'll see that most of our acute bilirubin encephalopathies are in the first week. In that time, the blood-brain barrier is still very porous, is still very permeable to unconjugated bilirubin. Thank you.
Okay, my hand is up. Can I please ask the question?
Yes. Ask the question. I answered the question.
No, my sister is here to help me out. So thank you for the opportunity to chip in, and a huge congrats to my sister and chief, Professor Ezeaka, for a well-delivered, as always, well-researched presentation. Congratulations, ma'am. And I'm particularly very, very delighted with the topic under discussion today, because it's a topic very close to our hearts as neonatologists. And I'm most excited that it is even being delivered to mostly teen leads in private practice. As you're well aware, a lot of the patients that come with jaundice and come in late come either from private healthcare facilities or from primary healthcare centers. In my own experience, these are the two major sources of late presentation of cases of jaundice. Of course, also from home. Sometimes they're discharged early, they go home and they don't present until it's too late. So although most of the people that are on this platform are from the big private hospitals, but nevertheless, it's a start, and word will spread across to the smaller private practice that it's so important to monitor for jaundice before discharge, and also to give appropriate instructions on what to do and how to actively search for jaundice. So I'm happy about that. That's a comment. The second comment I have is that we must begin to look at jaundice as a public health issue. Because if we keep waiting for them to come to the hospital for us to treat them, then we're never going to win this fight. We must, as a body, add our voices to any medium that can promote knowledge and change of cultural beliefs about jaundice and how to treat it and when to come to hospital. Because that's the only way, since we do not have an active community follow-up scheme in the country to trace these patients from the community. But a lot of our people listen to the radio, watch television. The more elite ones are on social media. So we must use all avenues possible to talk to people about jaundice and what to do about it. So I'm just corroborating that need, which our speaker has already mentioned. The only question I have for you, Ma, is regarding the photoirradiance. There was a slide that you showed us that the photoirradiance is best when the baby is about 10 cm from the machine. And I just want you to clarify, would it be with any machine or just the LED bulbs? 10 cm with conventional phototherapy, don't you think that the heating would be much? Or what has been your experience? Thank you.
Okay, thank you so much, Dr. Mukta. Yeah, this was the slide. Yeah, this is a research work that showed the effect of using the white light for increased reflectivity and then the distance. Yes, it's the ideal, the recommended is 10 to 15 centimeters. This is all in the literature. But to say that this was with the bulb, with the conventional bulbs, you're actually worried of overheating. That's a big side effect. But with the LED lights, the overheating is not actually a main issue, because you see that those LED, they don't overheat. So part of that recommendation is that most of us should actually move from these fluorescent lights. That was what was in the key messages. We should embrace, we should embrace new technology. We should use more of LED lights. We should use irradiance meters. We should avail ourselves to transcutaneous bilirubinometers and then we should utilize the point of care once it's available, because it's coming in this June. We're planning to launch it at the NISOM meeting, Nigerian Society of Neonatal Conference, this June 20th in Nigeria. Thank you.
Thank you very much, Professor. I have to bring the meeting to a close. It has been extremely, I think everybody that has spent time will say, yes, it was worth spending time. And your passion, your dedication is so transparent. So I put it to all of us to try and see how we I said we would all work together under our new association, working with other agencies to make sure that we put an end to severe jaundice in Nigeria and West Africa after we've done ours. Thank you very much, Professor for this wonderful lecture. And thank you
so much.
for being so much of the time to improve our capacity and to learn new things. Thank you.
Thank you so much. Some people were asking for the lectures which will be made available on the platform. So I wouldn't know the various media, how you got the information, so that the lectures will be shared. And some were also asking, where do we get the charts? So the comprehensive newborn care guideline, I will also post the electronic version on the platform so that it can be shared to your colleagues as much as, and then also post it on NISOM again, because it's being disseminated. So the appendix of that comprehensive newborn care guideline has all the charts, monitoring charts, critical care chart, admission record chart, the jaundice chart. So it's all advanced comprehensive. The kangaroo mother care, it has a chart for monitoring the baby. It has CPAP, if you're doing CPAP, it has the CPAP monitoring chart. So it has all this, because we're like, how do we move ahead beyond just the basics that we have been doing earlier? How do we improve on what we do? So the chart will be sent. A lot of questions were resonating around the charts, the materials, and the lectures. Thank you, everyone, for this opportunity for us to share knowledge amongst each other. Thanks.
Thank you.
Thank
you, Professor.
Thank you.
Let's work closer together. Thank you.
Thank you. Thank you so much, everyone.
Everybody. Have a nice night.
Thank you, everyone. Thanks for the time.
Thank
Bye.
you. Bye.
Bye-bye.
Nice
Thank you.
outing.
Thank you, Maria. Bye.
Thank you, Ma.
Appreciate you.
Bye-bye. Thank you.
Thank you, sir. Thank
Prof.
you.
Very nice to hear from you, and thank you, Dr. Dosekun, for ably managing the meeting very, very well. And I thank everyone for your contribution. We've had contributions from all over the country, Abuja, Enugu, all over the country and abroad. Earlier on, Dr. Jenny Fuja has been with us. Dr. Grange as well has been with us. People from America and people from the UK as well. I saw all of them. And it's been a wonderful session. Perhaps the longest we've ever had. And I thank the presenter for the patience. I mean, it speaks to your enthusiasm and passion for the topic.
Thank you, sir.
Yes, and this is an organization which I have to add very quickly that we are very proud of, because one thing we have achieved, which I'm very proud of, is that when we started this organization, we decided that it was going to be public-private. And that was deliberate. And it wasn't going to be private as secluded. And we are beginning to see the fruits of that now. And we are on the right course, and it will lead us into more areas where we can collaborate and work together, like Dr. Dosekun was talking about. So we have the foundation already laid here in the tertiary institutions, and they have been wonderful. So I'm really proud that at this meeting, we are like 70%, 60 or 70% of the group attended. I mean, there are not many meetings where you have 60 or 70% of the membership attending meetings. It speaks to the enthusiasm. Unfortunately, many of them have left now. So it speaks to the enthusiasm of the members, and also the hard work of the committee for choosing topics that are relevant and that are of importance, and for bringing in the great speakers like Professor Ezeaka today. So, I just want to thank everyone on that note. I know Dr. Dudu was supposed to say a vote of thanks, but for this purpose of those who are left, I'm really very, very proud of today's meeting. And I want to thank everyone again. Thank you all.
Thank you, sir. Thank you so much, sir. Thank you, everyone. Bye.
Thank you very much. Bye. Bye.